Hello friends, in our previous video we have discussed about graft rejection, okay, and in this video we are going to discuss about cancer immunology. Okay, so tumor immunology involves the study of antigens on tumor cells and the immune responses to those antigens. Clear? So first we will discuss about tumor antigens. What are the tumor antigens involved? So two types of tumor antigens have been identified on tumor cells. Okay, the first type is known as TSTA, that is tumor specific transplantation antigens. The second group of antigen is known as TATA, that is tumor associated transplantation antigen. Clear? So these are the tumor specific, these are tumor associated. So first we will discuss about tumor specific transplantation antigens. So these antigens are present only on tumor cells. Okay, they are the characteristic of only tumor cells. They are not present on normal cells. So they are absent on normal cells and they are only present on tumor cells. So they are known as tumor specific. Okay, now they may result from this TSTA antigens may result from your any mutation which is occurring in tumor cells, okay, that had generated altered cellular proteins. So they may result from mutation in tumor cells that generate altered cellular proteins. Now these mutation induced altered cellular proteins undergo cytosolic processing, okay, and it will give rise to novel peptides that are presented with your class 1 MHC molecules, okay, including a cell-mediated immune response by tumor-specific cytotoxic T lymphocytes. Clear? So once again revising, cytosolic processing of those proteins will give rise to novel peptides that are presented with class 1 MHC molecule, inducing a cell-mediated immune response by tumor-specific cytotoxic T lymphocytes. Clear? Now, these TSTA are induced on tumor cells either by chemical carcinogen or by physical carcinogen or by viral carcinogen. So these types of antigen may be induced by your chemical carcinogen, physical carcinogen or viral carcinogen. Okay, but there is a difference between viral carcinogen or physical and chemical carcinogen. So in chemically and physically induced tumor, the TSTA is tumor specific. Okay, it means different tumors possess different TSTA even though induced by the same carcinogen. So same carcinogen causing different tumors have different antigens. Getting? So different tumors possess different TSTA even though they are induced by the same carcinogen. Okay, one example, suppose methyl cholanthrin and UV light are the examples of chemical and physical carcinogen that are extensively studied. Okay, these two. UV light is more important. Clear? So the carcinogen is same UV, but it is going to form different antigens in different tumors. Clear? Now coming to the viral. So in contrast to this chemical and physical carcinogen, the TST or virus induced tumor is virus specific. So the antigen is virus specific here. Clear? All tumors produced by one virus would possess the same antigen. Example, your Epstein-Barr virus, which causes nasopharyngeal carcinoma and several other types of lymphoma, have same type of antigen, that is TSTA is same. So if viral is the cause, then it will form virus specific, and if chemical and physical agents there, then it is forming tumor specific antigens. Clear? So this is about your TSTA, that is tumor specific transplantation antigens. Now we will discuss about TATA, that is tumor associated transplantation antigens. So these antigens are not unique to tumor cells. Okay, they are not unique to tumor cells and they can be expressed by normal cells also. So they are also present on normal cells, but at a very low level. It is present on normal cell, but very low level of these antigens are present in normal cell. Clear? Their levels get exponentially high in tumor cells. Getting? Now we will include two examples here. The first one is your oncofetal antigens. So they are the proteins that are expressed on normal cells during fetal life but not expressed in the adult normally. This is the normal condition. But there is reactivation of embryonic genes that encode those proteins in tumor cells, which results in the expression on the fully differentiated tumor cells. So their reactivation can occur in tumor cell. Okay, and examples are AFP, that is alpha fetoprotein. Okay, AFP alpha fetoprotein, and also CEA, that is carcinoembryonic antigens. So these are the two examples which are coming under the oncofetal proteins. Now this alpha fetoprotein is associated with your hepatoma tumor, okay, and also testicular cancer. And this CEA, that is carcinoembryonic antigen, is associated with your GIT cancer, lung cancer, and ovarian cancer. So they are once again dividing your oncofetal antigens. So they are proteins that are expressed on normal cells during fetal life but do not express in the adult normally. Okay, reactivation of these embryonic genes that encode these proteins in tumor cells result in the expression on the fully differentiated tumor cells. Examples are two, that is AFP, okay, alpha fetoprotein, which is seen in hepatoma and testicular cancer, and CEA, which is seen in GIT, lung and ovarian cancer. Clear? The next group is your non-oncofetal, okay, and it includes examples such as your carbohydrate antigens such as CA125, CA199, or prostate specific antigen, and macroglobulin. Clear? So this CA125 is associated with your ovarian cancer mainly. Okay, CA199 is associated with other many carcinomas. Okay, this PSA is associated with prostate cancer, and this beta 2 microglobulin is associated with multiple myeloma. So these are the tumor associated transplantation genes. So we have discussed two antigens, that is TSTA, tumor specific transplantation antigen. Then we have discussed about TATA, that is tumor associated transplantation antigens. Getting? In this we have differentiated between physical, chemical, and viral antigens. Clear? So this is the general introduction. Now we will look for immune response against tumor cells. What are the immune responses against the tumor cells? So both humoral and cell mediated immune responses are induced by tumor antigens that results in the destruction of the tumor cells. So both cell mediated and humoral mediated immune responses are seen against the tumor cells. This is the first point. Okay. Now in general the cell mediated response appears to be the main role, appears to play the major role. Okay, and especially the involvement of cytotoxic T cells and your NK cells. So the main immune response is mediated by cell mediated immunity, and most important, cytotoxic T cells and NK cell involvement is seen there. Now coming to the discussion of cytotoxic T cells. So a number of tumors have been shown to induce tumor specific cytotoxic T cells that recognize tumor antigens, which is presented by your class 1 MHC molecules on the tumor cells. However, as the expression of class 1 MHC molecules are decreased in a number of tumors, thereby limiting the role of a specific cytotoxic T cells in their destruction. Okay, so in many tumor there is decreased amount of class 1 MHC molecule. So there is decreased functioning of the cytotoxic T cells, because these cells are only functioning when there is antigen presentation by class 1 MHC molecules. Now coming to the NK cells. So the recognition of tumor cells by NK cells is not MHC restricted. This is the first point which we are knowing from previous video, that recognition of tumor cell by NK cell is not MHC restricted. Clear? The activity of NK cells is not compromised but enhanced by the decreased MHC expression enhances your NK cell activity. Okay, this point is very important. If there is decreased MHC expression, there will be increased NK cell activity. Clear? Now why this is happening? So this is due to withdrawal of inhibitory receptor induced NK cell suppression. Okay, the inhibitory receptors of NK cells will no longer function in the absence of MHC1 molecule. So if MHC1 molecules are decreasing, then your inhibitory receptors which are present on NK cells get down regulated. Okay, so there will increase functioning of the NK cell. Getting? Now so inhibitory receptors are down regulated and activation receptors are coming in more number. Clear? So the activation receptors can be your FC receptor on NK cell, which can bind to antibody coded tumor cells, and that can lead to your ADCC. Clear? So this may be one mechanism. The most important point here, that is the importance of NK cell in tumor immunity, is suggested by the mutant mouse strain, which is called as BASE, and in human it is known as Chediak-Higashi syndrome. Okay, Chediak-Higashi syndrome. So this is important from your MCQ question, what is Chediak-Higashi syndrome. So again, revising, the importance of NK cell in tumor immunity is suggested by mutant mouse strain called BASE, okay, and Chediak-Higashi syndrome in humans. In each case, a genetic defect caused marked impairment of NK cell and an associated increase in certain types of cancer. So if there is mutation in NK cells, then there will be increased incidence of cancer, that is known as Chediak-Higashi syndrome. Okay, so this is about your immune response against tumor cells. So there is involvement of both your cellular and humoral mediated immunity, okay, and mainly T cell and NK cell is shown. Okay, cytotoxic T cell has limited role because of the down regulation of class 1 MSC molecules, but NK cells is not MSC restricted. And one more important point, that decreased MSC expression increases NK cell activation, because if MSC1 molecules is down regulated, then there is inhibition of this inhibitory receptors on NK cells, and there is more expression of activation receptors that can mediate your ADCC. Clear? One important point, that is Chediak-Higashi syndrome. So this is about immune response. Now one more important topic, that is known as immune surveillance. Okay, immune surveillance theory. So changing the color once more. So theory of immunological surveillance postulate that the tumor cells may arise frequently in our body but are recognized as foreign and are eliminated by the constant vigilance of our immune system. So once again repeating, this postulate that the tumor cells may arise frequently in our body but are recognized as foreign and are eliminated by the constant vigilance of our immune system. Clear? So later on, Lewis-Thomas, one scientist, that is Lewis-Thomas, revived the theory by suggesting that the role of cell-mediated immunity, okay, to the means he has said that there is role of cell-mediated immunity, okay, in patrolling throughout the body and eliminating cancer cells. So there is involvement of cell-mediated immunity here. Clear? Now the next point, that is immune evasion by tumor cells. Okay, immune evasion by tumor cell. Though the immune surveillance hypothesis looks attractive, but it does not hold always true. In real situation, there are a number of immune evasion mechanisms by which tumor cell bypasses the immune surveillance mechanism. The first mechanism is your anti-tumor antibodies. Okay, so anti-tumor antibodies produced against tumor antigens may have a role in immune evasion. How? So there are two types of factors. The first one is your blocking factor. So once again I am telling that anti-tumor antibodies produced against tumor antigens may have a role in immune evasion. So first discussing an important point, blocking factor. So anti-tumor antibody may act as a blocking factor. The antibody binds to tumor specific antigen and masks the antigen from cytotoxic T cell and NK cell. Suppose this is a tumor and its antigen is here. Okay, so this anti-tumor antigen will come and bind to this antigen and does not allow your T cell to recognize these antigens. Okay, this is one mechanism acting as blocking factor. The second one is your antigenic modulation. So certain tumor specific antigens have been observed to disappear from the surface of tumor cells in the presence of serum antibody and then to reappear after disappearance of serum antibody. That is known as antigenic modulation. Clear? So blocking factor and antigenic modulation, the first. The second one is your masking the immune cells. So circulating tumor antigens may act as a smoke screen, coating the lymphoid cells and preventing them from acting on the tumor cells. Okay, so the masking of the immune cells is occurring here. The third one is your expressing low levels of MHC 1. Many tumor cells down-regulate the expression of MHC1 molecules, hence preventing their recognition by cytotoxic T cells. Clear? The fourth mechanism may be by poor co-stimulatory signal. There may be poor co-stimulatory signal between CD28 and B7. Clear? So these are the most important reasons why a certain tumor is bypassing the immune surveillance. The next reason is certain soluble factors. Okay, so certain tumor cells secrete soluble factor such as your interleukin 10, TGF beta that may suppress the immune responses against the tumor cells. So these are important MCQ question. Interleukin 10 and TGF beta may suppress the immune response against the tumor cells. The next reason is the expression of FAS ligand. Some tumor cells express FAS ligand on their surface, which then interacts with the FAS on the T cells and causes apoptosis of that T cells. Clear? So these are the main reasons: anti-tumor antibodies, masking the immune complexes, decrease MSC1, poor co-stimulatory signals, soluble factors, interleukin 10 and TGF beta, expression of the FAS ligand. Getting? Now, so this is immune surveillance and how the cells are escaping from that. Now the last part is your cancer immunotherapy. Clear? So cancer immunotherapy is the use of immune system to treat cancer. Three main groups of immunotherapy are used to treat cancer. The first group is your cell-based therapy. The second is your monoclonal antibody therapy. Okay, and the third one is your cytokine therapy. So these are the main therapy which are using for cancer. So first we will discuss about this cell-based therapy, then we will go for antibody therapy. So coming to the cell-based therapy. So cell-based therapy, also known as cancer vaccine, usually involve the removal of immune cells from patient with cancer, either from the blood or from a tumor. Okay, then immune cells specific for the tumor will be activated, okay, grown and returned to the person with cancer. So the first step in this is removal of immune cells from patients with cancer, either from the blood or from a tumor. Then immune cell specific for tumor will be activated, grow, and it is returned to the patient. Okay, and after that there will be immune response will be there, where the immune cells provoke an immune response against the cancer. Clear? Now cell types that can be used in cancer vaccine include your NK cells, cytotoxic T cells, as well as dendritic cells. The only cell-based therapy currently approved for use is your dendritic cell therapy. This is very important. Okay, and this is used for your prostate cancer. Clear? Now coming to the antibody therapy. So monoclonal antibody therapy are currently the most successful form of immunotherapy. So this is the most successful form of immunotherapy, the first point. The next is your, they are usually targeted against the cell surface molecules such as your epidermal growth factor receptor, and this antibody, once bound to the surface receptor on the tumor cell, antibody can induce tumor cell death by several mechanisms. Maybe the ADCC, okay, maybe complement activation. Okay. Now the next point, conjugated monoclonal antibody. Involvement of conjugated monoclonal antibody is this. So when such monoclonal antibody conjugated to a toxic molecule is used, suppose when a monoclonal antibody conjugated with a toxic molecule, okay, then this monoclonal antibody binds to receptor on tumor cells and delivers the toxic molecule to exert lethal effect on the tumor cells. Suppose this is a tumor cell, so monoclonal antibody with toxic cells. So suppose this is a monoclonal antibody and this is a toxic chemical. So once this antibody binds to tumor cell, this toxic chemical releases inside the tumor cells and causes lysis of these tumor cells. So this is known as conjugated monoclonal antibody technique. Clear? Now monoclonal antibody approved for treatment of therapy are here we are going to discuss. The first one is alemtuzumab. Okay, that is alemtuzumab. It target CD52, okay, and approved for treatment of CLL, that is chronic lymphocyte leukemia. The next one is your bevacizumab. It is bevacizumab. It targets vascular endothelial growth factor, and it is approved for treatment of colorectal, lung and renal cell cancer. Okay, bevacizumab. The next one is cetuximab. Okay, it is targeting epidermal growth factor receptor. It is also for your colorectal, head and neck cancer. Cetuximab. The next one is your ipilimumab. It is targeting your CTLA4 and it is for your metastatic melanoma. The next one is your rituximab, that is targeting CD20 and it is used for CLL. The next one is your tocilizumab. It is targeting CD20 and it is used for non-Hodgkin lymphoma. The next one is your trastuzumab. It is targeting your ERB-B2 and it is used for breast cancer. So okay, so they are the monoclonal antibody which are approved for the treatment of cancers. Now the last one is your cytokine therapy. So administration of cytokines can regulate and coordinate the behavior of immune system. The first one is your interferon alpha. So it is used in the treatment of hairy cell leukemia, AIDS-related Kaposi sarcoma, follicular lymphoma, chronic myeloid leukemia and malignant myeloma. Okay, so this is used in hairy cell leukemia, AIDS-related Kaposi sarcoma, follicular lymphoma, chronic myeloid leukemia and malignant melanoma. The next one is interleukin-2. It is used in the treatment of malignant melanoma and renal cell carcinoma. Clear? So these are all the three therapy which are given in the cancer. Okay, so this is all about your cancer immunology. So thank you for watching.